Hi, this is Elizabeth Joyner, and I chose to do my care plan presentation on pneumonia. It's one of the most common things I see with our patients on the floors. Also, just wanted to give you guys a little bit of background about the hospital I've been doing my clinicals at. We have 6 floors. That also includes a neuro ICU, critical care unit, a normal ICU unit, and the ER. We're known as a heart hospital, so people come to have any kind of heart or cardiology procedures like CABGs, or we have a cath lab, so we see those kind of patients, and normally when they're done, they go to the critical care unit before they get transferred to the floor. We also do orthopedic surgeries, and we also have a neuro ICU, any kind of head traumas or anoxic brain injuries. They go there. Traumas normally get diverted to another hospital. Also, any peds cases, NICU, baby deliveries, they also go to another hospital. So we have 3 in the area that I live in. Otherwise, we see and keep any pulmonary cases, like the one I'm about to tell you about. So just some basic patient demographic information. He's male, 81 years old. He's 5'7", weighs 90 kilograms or 180 pounds. He got admitted on February the 28th, and he is a full code status. Oh, that was nice. So what we know about his existing respiratory history, he was diagnosed with lung cancer. He wasn't sure what kind or couldn't say what stage he was in. We don't know if it was small cell or non-small cell. But we know that he had a right upper lobe lobectomy 4 months ago via VATS, which is a minimally invasive procedure where they go in and remove the piece of the lung. It's less recovery time, and he was able to go home fully recovered. He did used to smoke. He quit 40 years ago, and he was up to 1 to 1.5 packs a day. I don't think his occupation played much into his lung cancer diagnosis or any respiratory exacerbations that he's having. He told me he was retired, but he used to be a landscaper in Florida. So some other medical and surgical history that we know of. He does have CAD, which is coronary artery disease. He has high blood pressure, so he's hypertension. Paroxysmal AFib, which is paroxysmal atrial fibrillation, and that just means that he has rapid erratic heart rate, comes on suddenly, and then it'll usually stop within 7 days or so, and he does take medication for that. He did have a bilateral or both knees replaced. He also had his right femur repaired, a lumbar disc repair, right hip replacement, right shoulder replacement. He did tell me that he got hurt on the job, and these are results of that injury or fall that he had. So for his general appearance, I saw him on the floor in PCU, the Progressive Care Unit, on March the 4th, so it was 4 days after he was admitted. So he was already stabilized in the ER and moved to his room on the 3rd floor. His skin color was normal, and he was warm to the touch. He was also alert. He was able to give me, his history. I was able to talk to him, and he told me what happened while they were in town, so he was coherent enough to tell me what was going on with him, and his wife was also there as well. Accessory muscle use, I would say he was mildly labored, and what I mean by that is he didn't look like he was struggling to breathe like I imagine he would have when he first came into the ER. Did look like when he was talking to me, he had to stop and kind of catch his breath a little bit, but it didn't look like he was struggling to breathe. Diaphoretic, no, I didn't see him any kind of sweating. His breathing pattern was also regular. I didn't see any edema, any swellings in his lower extremities or even in his hands. Everything looked normal. Didn't have any digital clubbing or cyanosis, nothing like that. Chest expansion was also normal. He had a normal rise and fall every time he took a breath. So his vital signs as of March the 4th, so again 4 days after his admission and was transferred to the floor, for my assessment, he had a heart rate of 81, which is within normal limits. Respiratory rate or beats per minute, breaths per minute were 20, a little on the higher side, but still within normal limits. His SpO2 was 93%, a little lower than we would have liked to see, but again, he's still coming up from that 65% that he initially presented with. Blood pressure was 119/71, which is normal, and his temperature had also come back down from 101.9, so 102 degrees, to 97 degrees. And at this time, he was on 6 liters with a nasal cannula. And his breath sounds or lung sounds, he had crackles on both sides. So these were his lab values, and I put the dates on here that they were drawn. I'm not really sure if it just depends on the doctor or if there's an additional cause for why labs get drawn on different days, but I just wanted to point out that these were drawn on different days, so they weren't all drawn when he initially came to the ER. But on the 28th, which was his admission date, he had an elevated white blood cell count, 12.57. Red blood count was 5.9. Hemoglobin was 16.4. Hematocrit was 50.8. All of those are high. His platelet count was within normal range at 247. And they also did the procalcitonin test, which I mentioned earlier is a good indicator of infection. It was elevated at 2.07. So fast forward, you see, 2 days later, on the 2nd, he had an INR value of 4.5, which is extremely high. We know that it needs to be less than 1 to be within normal range, so it's almost 4 times over. Then on the 3rd, he had a BNP, which showed that he had low sodium at 132. Potassium's normal. His chloride was a little high at 110. BUN was normal at 21. Creatinine normal at 0.7. The albumin was low at level 3, and then his glucose was high at 189. Other things of note that I didn't put on this slide, it did have a lactic acid of 1.9. He did not have a BNP test. So again, I'm not sure who decides when things get ordered, I guess, as they progress with their stay and they're trying to figure out basically what else could be going on, why they aren't improving or is improving as fast. They start looking at other values to try to determine or improve their treatment. So I have here what his ABG was on the 28th. Everything was normal except his PaO2 was still low. It was drawn while he was on CPAP at 100%, and I did not see any ABG that was documented previously before placing him on CPAP. What I've seen in the notes is they usually get one before, and then place them on whatever device, and then 30 to 45 minutes later they have another ABG drawn for comparison. Maybe he was so acute that they didn't have time to get an ABG, that he immediately needed to have that O2 therapy because of his moderate hypoxia, and his sats were at 65%, so they immediately knew that he needed some O2 therapy. And again, I would assume this was drawn 30 to 45 minutes after he was already placed on that CPAP. So as I'm sure everybody knows, I couldn't put his actual chest x-ray on this PowerPoint because of HIPAA. But what I normally do every time I go to do a care plan is I try to look at the chest x-ray first and come up with my own analysis, and then read the physician interpretation and see if I am getting better at my interpretations and just starting to pick up on trends with patients. So he had a chest x-ray on the day of his admission, the 28th, and we could see that his heart was normal size. He did have bilateral infiltrates. I could see that his left upper lobe area was the clearest out of all of his lobes. He did have that right upper lobe consolidation, and then I could also see his diaphragm was clearly visible, and it was in that normal dome shape as you would expect to see. And then the MD interpretation, he had bilateral bronchopneumonia superimposed on COPD, so that could certainly explain why his sats were lower than normal. He could have COPD and just not be diagnosed with it yet, or that could just be the MD's interpretation based on the information given. And then he had another one taken on the 3rd, so a few days later, only showing slight improvement. One other thing I did want to talk about his chest x-ray and connections we can make between the patient and their imaging scans. I did notice that his infection was confined to the right upper lobe. That's where you could see most of that consolidation. And this is due to that horizontal fissure, that separates the right upper lobe from the right middle lobe. So that's kind of where, whenever patients aspirate, it typically goes to that right side because of the angle of the bronchostem. It's just easier, liquid follows the flow of gravity, so it's going to go the path of least resistance, so it's going to tend to go down to that right side. So now we can move on to the signs and symptoms of improvement. Well, we certainly know that his SpO2 is improving. We can easily look in the chart and see that he went from 65% all the way up to 93, and he was placed on CPAP to begin with. Then he was traded to a 15-liter non-rebreather mask. Then he went down to a 12-liter pendant and down to that 6-liter nasal cannula that I saw him on when I went in and did my assessment. Also, his temperature, heart rate, and respiratory rate all returned within normal limits. And then I looked at the labs for his white blood count, or white blood cell count. They did draw that every day, and it was back within normal range on day 4. Suggestions for treatment. I Definitely do recommend or support the physician's plan of treatment. He has a pulmonologist specialist come and see him every day, as well as a hospitalist who follows their care every day. So I was able to look at all their progress notes and feel like they were on the right course of treatment. Some other things I think they could switch to when ready is instead of getting everything through IV, he could go to by mouth antibiotics. Also, I think it's important to educate the patient on what to do the next time this happens, since there does seem to be a history of recurrence. We want to educate them that he needs to go to urgent care at the first sign of distress. When he vomited those 2 days before that he initially didn't tell us about, and then it came out later when the daughter came. It made it into the note that she said that he had vomited, but they didn't want to miss out on any wedding festivities. They were in town because she was getting married, and I could definitely see them not wanting to impose on any of the wedding festivities by having to leave and go to urgent care or a hospital. But we definitely want to educate them, and this very well could have been prevented. So the severity of the respiratory condition, he was definitely acutely severe. As I mentioned before, they were in town for their granddaughter's wedding, and I definitely got the impression that they wanted to wait and get back home to seek out treatment, which I can understand. When you're out of town and you just want to get back home because you don't feel good, so I could definitely see why things were elevated, and a lot of this could have been avoided, and a long hospital stay could have been avoided if they would have just sought out treatment earlier. I definitely do think there were clinical signs before he became septic, and they are aware of his chronic aspirations. But again, I agree that they probably just wanted to wait and get back home and get treatment there. He has a pulmonologist back in Tampa, so I feel like they were going to make an appointment once they got home, and ultimately during the night before they were due to go home is when everything got exacerbated, and ultimately 911 had to be called, and EMS came and transported him to ER in the middle of the night. I believe I read that he came in around midnight. So these are his non-respiratory medications. He was on a host of other ones, but these were the ones that were most notable. He was on Cortisone, 200 milligrams by mouth daily. This treats irregular heartbeat, so I feel like this was what was being used to treat his paroxysmal AFib. He also was on labetalol, 10 milligrams via IV, Q3 also as needed to help control his high blood pressure. It's also on prednisone at 20 milligrams by mouth per day. This is helping decrease the inflammation that he's got going on. We all know that that's a pretty common steroid that used to treat multiple things. So in his case, it was helping treat his inflammation caused by the pneumonia in his lungs. He's also on Coumadin, 5 milligrams by mouth every day. This is an anticoagulant. It's an older drug, and I just know this from previous history. People being on blood thinners, this is one that they don't typically prescribe anymore. Usually you see people on Eliquis or Lopinox, things like that. So I just recognize that this is an older type of drug, and this tells me that he's been on it for a long time. He also is on piperacillin tazobactam. This is help treating that bacterial infection, pneumonia. He's on 100 mils at a drip of 2.5 mL an hour every 8 hours, and again, it's via IV. So the only respiratory medication he was on was the Duonev at 3 mL via nebulizer as needed. This is a pretty common bronchodilator that I see in the hospital. Almost everybody gets this. By the time we saw him 4 days later, he was switched to as needed, but I did see in his chart previously that he was on it every 4 hours. Usually when they go to PRN, we just check on them once a day, see if they want to take their treatment. If not, they definitely don't have to take it. But they do know that the order is in there, so they could always just ask the nurse to call us and we'll come up and give them the treatment. Most commonly, people choose to take the mask that hooks onto the nebulizer so they don't have to place their mouth around it. It's just they feel like it's easier just to breathe in and take the treatment that way. We put them on at 5 liters and switch it on, and the treatment usually lasts about 10 minutes, and we leave it on until we start to hear it sputter. And then, of course, after they're done, we tell them to give us a big cough. When we saw him that day, it did sound wet, but it was non-productive. So we do know that he was having some sputum production earlier on, but not so much, at least not that day that we were in there and saw him. He didn't have any non-productive cough. So for expected outcome short term, we still want to continue to wean his oxygen. We want all of his medications to be switched to by mouth. We want to make sure that he can ambulate well, get up and walk, make sure he doesn't experience any shortness of breath or increased work of breathing as he's, just getting up to go to the bathroom, put his clothes on, walk down the hall, that sort of thing. We want him to finish all of his steroids and antibiotics as well. Some of those can be prescribed and taken home and finish them at home. We also do need his INR value to be returned to normal limits before he gets discharged. I did a little bit of research, and it could be elevated due to his prescribed Coumadin. They do have to closely monitor that, so that does have to be returned within an acceptable rate before he gets discharged. So expected outcome on the long term, I would expect him to have an AMOX test to determine if he's going to need any home oxygen when he gets discharged. Basically, one of the therapists on the diagnostics team will come and do an ambulatory test, kind of as I mentioned before, and see if he's going to need to go home on any oxygen. Hopefully not. Our goal is always to send them home without oxygen, and we don't want them to become dependent on it. We also want to discharge him and continue with any oral medications that will be prescribed by his physician. I would also recommend that he gets routine chest x-rays or CTs to monitor his lung cancer, make sure there's no recurrence with that. Also, I definitely recommend that once he gets home, he goes ahead and makes an appointment with his current pulmonologist, and he be seen every 1 to 3 months for follow-up. So these are the differences in expected presentation and the actual presentation with pneumonia and my patient. Everything pretty much returned to normal limits except that INR value that we already talked about. So his respiratory rate, temperature, heart rate, blood pressure, all was within normal limits when I saw him. But I would like to make it of note that they all were elevated when he presented in the ER. I could see his vitals then, and they all were part of that expected presentation that you see on the left side. As I mentioned, his breath was slightly labored compared to shortness of breath, which I would expect to have seen him look like in the ER. I mentioned he had a wet, non-productive cough, which is to be expected. Sometimes it's harder to get all of that sputum out, but that's why he continues to be on those antibiotics, and that DuoNeb treatment certainly help clear that up. Sputum culture was normal. He didn't have any hemoptysis, so no blood in his sputum, and then it was expected for him to have crackles, which he did present that way, which certainly makes sense why he had a wet, non-productive cough, because of that fluid in his lungs, and you could hear it mostly in the bases. So just some final thoughts to wrap up. I've just noticed some trends with patients, especially with pneumonia. What tends to happen is once the patient comes to the ER, they get stabilized there, and they usually hang out there until they can get a room on the floor. And they normally go to PCU, like I mentioned, which is the progressive care unit, until they get discharged. And they get treated with IV steroids, oxygen supplement, and titrate down, wean them off, hopefully, so they're not discharged on any home oxygen. And then they switch to medications by mouth and finish them at home. So I hope you enjoyed my presentation on pneumonia. If you have any questions, please let me know. Feel free to reach out. I look forward to reading all of your comments. Thanks.